Cervical auscultation is the technique of listening to the swallow using a device such as a stethoscope in order to assess an individual's swallow and make judgments about their airway safety and impairment based on the perceived normality of the sounds. ASHA's website provides several articles listed as resources for the review of the literature on cervical auscultation. Among these reviews listed, the one in favor of cervical auscultation only met half of the article quality rating requirements, while a review suggesting insufficient evidence met all 6 quality standards. According to this 2016 review by Lagarde, Kamalski, and Engelhoek on the reliability and validity of CA in the diagnosis of dysphagia, there is currently very little reliable and valid evidence found in the literature to support CA as an accurate tool of assessment when combined with other modes of assessment, and especially when relying on it alone to make clinical judgments and recommendations. We will now address some of the specific limitations and lack of evidence reported in the literature.
A major criticism of CA is that the physiologic events and the timing sounds that are heard do not consistently match up with each other. And in a study conducted by Leslie et al. With 19 healthy volunteers, they performed CA while simultaneously performing a FEES, and they were able to distinguish 6 sounds, but none of them occurred in all swallows, and there was a very wide spread and large degree of overlap of the timings of the swallow sounds and the physiologic events. There is no robust evidence or data to support the inclusion of CA in clinical practice or protocols.
According to Dudek, Coyle, and Sage's research on cervical auscultation signals and their contributions to dysphagia screenings, the patient must remain very still. If the patient does not remain still, specific unwanted signals can be found in the data. Clinicians are already listening for such obscure sounds as clicks and pops, so any slightest head motion can result in unwanted biasing.
According to Leslie et al., sounds such as the pre-click in the onset of apnea, the pre-click in the start of the epiglottic excursion, and the click in the epiglottis returning to rest, the click in the end of the swallow apnea, there is no evidence of a causal link. Bolzen et al. Verified that this is a subjective method of assessment. It is subjective because it was difficult to establish an agreement among examiners, and it did not contain specific data of physiological correspondence.
A study by Stroud et al. Assessed inter-examiner reliability when recording the cervical auscultation sounds to detect the presence or absence of aspiration in dysphasic patients. The cervical auscultation sounds were recorded parallel to a fluoro being performed. 5 SLPs with previous training in cervical auscultation listened to the sounds recorded in 2 distinct moments. The inter-examiner comparison was a kappa index of 0.28, indicating a weak level of agreement. It was also possible to verify a high incidence of false positives in the absence of aspiration. This could lead to overdiagnosing and SLPs inappropriately restricting patients' diets.
Cervical auscultation should not be relied on by itself to diagnose dysphagia or aspiration related to dysphagia. Carnaby, Mann, and Linnaeus states that the most important function of an assessment is to understand the physiologic nature of the patient's swallow in order to select appropriate therapeutic strategies. CA does not allow the clinician to directly assess the physiology of the pharyngeal phase and would not allow the primary pathophysiology to be identified. Further, the principal aim of CA is to determine only whether or not the patient aspirated, which according to Carnaby, Mann, and Linnaeus is only one non-obligatory component of dysphagia, and CA does not necessarily address other components. Information on sensitivity and specificity of CA has not been well established. Therefore, those performing it run the risk of falsely identifying individuals or missing individuals who do aspirate, which according to Carnaby, Mann, and Linnaeus article could respectively result in unnecessary introduction of non-oral feeding methods or serious complications such as pneumonia or death. Instrumental imaging is essential for detecting abnormalities and impairments in the swallowing process and is currently the only reliable objective measure.
Another pitfall of cervical auscultation is that it can only be utilized with a specific infant population. Approximately 15 million babies are born prematurely every year. This is roughly 1 out of every 10 babies, and 4 in every 1,000 babies are neonatal deaths. Several conditions resulting from premature birth may adversely affect swallowing function, including hypotonicity, decreased laryngeal sensation or elevation due to tracheostomy, as well as limited suckling experience. It is extremely important to identify pediatric dysphagia to avoid failure to thrive or infant death. While it could be argued that CA may be the better option for assessing dysphagia in infants because it eliminates the factor of exposure to radiation, CA is currently not used with infants under 12 months. This is because infants' swallow respiration pattern changes as they mature. This pattern changes once at 1 week of age and again between 6 to 12 months of age, and is due to anatomical maturity, including increased oral cavity size and a more vertical position of the trachea. While the 2013 study was able to collect recordings of two-day-old infant swallow sounds, there was significant variance between neonates swallowing sounds, and the resulting definitions were unclear.